Hi, everyone. It's Victor from Cardiac Wire, and today I'm joined by Dr. Martha Galati here at the American Heart Association's 2025 Scientific Sessions to talk a bit about heart failure and the treatment landscape. Kerendia, or finerenone, was approved by the U.S. Food and Drug Administration for the treatment of adults with heart failure with left ventricular ejection fraction, or LVEF, of 40% or more, commonly known as heart failure with mildly reduced or preserved ejection fraction. Heart failure with mildly reduced ejection fraction is classified with LVEF of 41 to 49%, and heart failure with preserved ejection fraction with LVEF of 50% or more. We recently had the opportunity to speak with Dr. Andrew Sauer about the clinical trial and data that led to this approval, as well as its impact at the Heart Failure Society of America's annual scientific meeting. So, if you haven't seen that episode, make sure to check it out.
Hi, everyone. And thanks for having me on, Victor, to talk about this important topic for the many people who are impacted. But before we jump in, Kerendia, finerenone, is indicated to reduce the risk of cardiovascular death, hospitalization for heart failure, and urgent heart failure visits in the adult patients who have heart failure with a left ventricular ejection fraction of greater than or equal to 40%. Kerendia is contraindicated for patients with hypersensitivity to any component of this product, concomitant use with a strong CYP3A4 inhibitor, or patients with adrenal insufficiency.
Great. Well, now that we've got that covered, could you tell us a little bit about yourself, Dr. Galati?
I'm Dr. Martha Galati, a professor of cardiology, and I lead the Davis Women's Heart Center in the Department of Cardiology at Houston Methodist in Houston, Texas. I'm really enjoying my time here in New Orleans, and I'm excited to share more about the latest updates on the heart failure treatment landscape.
Can you walk us through the typical journey and challenges a patient diagnosed with heart failure with preserved or mildly reduced ejection fraction may face?
Based on the patients that I see every day, I'd say the typical patient journey for those who have heart failure with preserved or mildly reduced ejection fraction often begins with acute symptoms or a cardiac event. That's usually when patients come into the hospital or see their cardiologist for an assessment and initial medical treatment. In my assessments, patients often come in with persistent symptoms like shortness of breath, nausea after eating, or swelling in different parts of their body. They might also notice or even be nervous or frustrated that everyday things like walking up a flight of stairs or cooking a meal have suddenly become really exhausting. Women can present with the same symptoms as I described, but these symptoms are often underappreciated when they occur in women. The road to diagnosis is often challenging and longer than necessary. As a result, there can be delays in medical therapies being initiated because of a later diagnosis. Women can also present with ANOCA, or also known as ischemia with no obstructive coronary arteries, before heart failure is actually diagnosed. This is because ANOCA and heart failure are closely connected, particularly for heart failure with preserved ejection fraction. Heart failure in women is often underdiagnosed and undertreated.
You've likely seen thousands of patients with heart failure throughout your career. What are the challenges you've observed specifically with patients with heart failure who have preserved or mildly reduced ejection fraction? Where do you see Kerendia making an impact?
Among patients with heart failure with preserved or mildly reduced ejection fraction, 21% with symptomatic heart failure escalate to hospitalizations for heart failure or cardiovascular death, and 25% who are hospitalized for heart failure are readmitted within a year. It's also been found that each hospitalization for these patients more than doubles the risk for cardiovascular death. I see the real world effects of the rehospitalization cycle all the time, especially in women whose incidence of heart failure has been increasingly more than men's, particularly among racial and ethnic minorities. Women are also twice as likely as men to experience heart failure with preserved ejection fraction. From my perspective, we aren't often thinking enough about the medications needed to reduce the risk of rehospitalization. A patient with preserved or mildly reduced ejection fraction may come to the hospital after an urgent heart failure event, and we'll typically start them on a diuretic or a sodium glucose transport protein 2 inhibitor, also known as SGLT2 inhibitor for short. Yet they often end up back in the hospital sometime after the fact with worsening symptoms. Helping my patients face this challenge is important, and Kerendia provides another tool to reduce the risk of cardiovascular death, hospitalization for heart failure, and urgent heart failure visits.
I feel like it's not widely known that women are increasingly at risk for heart failure, particularly heart failure with preserved ejection fraction. Can you explain more why that's the case?
Well, there are many reasons for this, but I'll touch on a few. Women have historically been underrepresented in heart failure studies, so we've known less about how it impacts them specifically. Women are, as you mentioned, more likely to have heart failure with preserved ejection fraction, which is not always appreciated and recognized by clinicians and may lead to an underdiagnosis. Unfortunately, women are also less likely to get appropriate heart failure treatments early on in the course of the disease, leading to delays in managing care. Biologically, the lining of a woman's blood vessel can change as they age or because of the presence of cardiovascular risk factors, which affects how the heart and vessels work together. That makes it harder for the heart to pump blood to the rest of the body efficiently, putting them at a higher risk for heart failure with preserved ejection fraction.
With all these challenges in mind, what makes Kerendia a core pillar of treatment for your patients?
That's a great question, and there are a few different reasons why I feel this way. A report published by the American Heart Association suggests that by 2030, the lifetime risk of heart failure is expected to increase by 23%, and the total number of adults living with heart failure in the United States will increase by 46% to over 8 million Americans. Looking at these numbers, it's clear the amount of people living with heart failure is growing significantly. Most treatment options in this space have historically focused on patients with heart failure with reduced ejection fraction or heart failure with a left ventricular ejection fraction of 40% or less. For women specifically, the lifetime risk of heart failure with preserved ejection fraction is nearly double that of heart failure with reduced ejection fraction. I see Kerendia as a core pillar for patients with heart failure with preserved or mildly reduced ejection fraction who previously had limited approved options.
That's a great point you bring up about the limited approved treatment options for these patients. Given that context, how do you see clinicians integrating Kerendia into a patient's comprehensive treatment plan for adults who have heart failure with a left ventricular ejection fraction of 40% or more?
Patients who may benefit from Kerendia include those who have been diagnosed with heart failure with a left ventricular ejection fraction of 40% or more. This includes those who have had a recent heart failure event, such as heart failure hospitalization or urgent heart failure visit, even with guideline-directed medical treatment. Since patients with heart failure often have multiple comorbidities, the use of guideline-directed medical treatments for heart failure often involves the use of multiple treatments. With the approval of Kerendia, clinicians can now have another option for treatment in addition to the existing diuretics and SGLT2 inhibitor medications available as a tool to help treat heart failure with a left ventricular ejection fraction of 40% or more. To learn more about Kerendia or review the full clinical data, go to www.kerendiahcp.com/heart-failure. Indication: Kerendia finerenone 10 milligrams, 20 milligrams, 40 milligram tablets is indicated to reduce the risk of cardiovascular death, hospitalization for heart failure, and urgent heart failure visits in adult patients with heart failure with left ventricular ejection fraction greater than or equal to 40%. Important safety information: contraindications, hypersensitivity to any component of this product, concomitant use with strong CYP3A4 inhibitors, patients with adrenal insufficiency. Warnings and precautions: hyperkalemia. Kerendia can cause hyperkalemia. The risk for developing hyperkalemia increases with decreasing kidney function and is greater in patients with higher baseline potassium levels or other risk factors for hyperkalemia. Measure serum potassium and estimated GFR, eGFR, in all patients before initiation of treatment with Kerendia and dose accordingly. Do not initiate Kerendia if serum potassium is greater than 5 milliequivalents per liter. Measure serum potassium periodically during treatment with Kerendia and adjust dose accordingly. More frequent monitoring may be necessary for patients at risk for hyperkalemia, including those on concomitant medications that impair potassium excretion or increase serum potassium. Worsening of renal function in patients with heart failure. Corindia can cause worsening of renal function in patients with heart failure. Rarely, severe events associated with worsening renal function, including events requiring hospitalization, have been observed. Measure estimated GFR in all patients before initiation of treatment or with dose titration of Corindia and dose accordingly. Initiation of Corindia in patients with heart failure and an estimated GFR less than 25 milliliters per minute per 1.73 meters square is not recommended. Measure estimated GFR periodically during maintenance treatment with Corindia in patients with heart failure. Consider delaying up titration or interrupting treatment with Corindia in patients who develop clinically significant worsening of renal function. Most common adverse reactions. From Fine Arts HF, the adverse reactions reported in greater than or equal to 1% of patients on Corindia and more frequently than placebo were hyperkalemia, 9.7% versus 4.2%, hypotension, 7.6% versus 4.7%, and hyponatremia, 1.9% versus 0.9%. Events related to worsening renal function were reported more frequently in the Corindia group, 18%, compared with placebo, 12%. Drug interactions. Strong CYP3A4 inhibitors. Concomitant use of Corindia with strong CYP3A4 inhibitors is contraindicated. Avoid concomitant intake of grapefruit or grapefruit juice. Moderate and weak CYP3A4 inhibitors. Monitor serum potassium during drug initiation or dosage adjustment of either Corindia or the weak or moderate CYP3A4 inhibitor and adjust Corindia dosages as appropriate. Strong and moderate CYP3A4 inducers. Avoid concomitant use of Corindia with strong or moderate CYP3A4 inducers. Sensitive CYP2C8 substrates at Corindia 40 milligrams. Monitor patients more frequently for adverse reactions caused by sensitive CYP2C8 substrates if Corindia 40 milligrams is co-administered with such substrates, since minimal concentration changes may lead to serious adverse reactions. Use in specific populations. Lactation. Avoid breastfeeding during treatment with Corindia and for 1 day after treatment. Hepatic impairment. Avoid use of Corindia in patients with severe hepatic impairment, Child-Pugh C, and consider additional serum potassium monitoring with moderate hepatic impairment, Child-Pugh B. Please see the full prescribing information for Corindia at www.corindiahcp.com/PI.
Thank you so much for the insightful conversation, Dr. Galati. We're grateful for your time, and thanks to all for watching the Cardiac Wire Show.